Very good morning to all of you. I welcome you all for this Wednesday webinar. And looking at the overall response last week, we continue with the case-based approach for neuromuscular disease. And today we'll be covering the neuromuscular disease presenting in childhood age group. I would like to request for President Dr. Shafali to give opening remarks.
Yeah. Thank you, Mahesh. So last time we had floppy case. Now this time we will have in a slightly older child, and we have two big stalwarts. Professor Satish Khadilkar doesn't need an introduction at all, and he's been very kindly, he's very generous to have joined. And we have the other expert is Professor Veda Narayanan, who did his MD Pediatrics from AIIMS New Delhi. He's 6 months senior to Dr. Durari, for whoever knows the dynamics here. And he's currently Chief Pediatric Neuromuscular Disease Professor of Neurology, Department of Neurology, Dell Children's Pediatric Neuroscience, University of Texas, Austin. He's going back to the US tonight, so he was just doing a security check. He'll just join in 10 minutes. And hand over to you, Gurpreet, to carry it forward.
Yeah, good evening. First of all, as we all celebrate Chandrayaan-3 landing on the moon, congratulations to all of us. And we will start with today's session. We have 4 cases today. The first will be presented by Dr. Abhishek Pandey and will be moderated by Dr. Renu Suthar from PGI Chandigarh. Then Dr. Anayata and Dr. Rotadeo from SRCC Mumbai. And then from Dr. Raju and Dr. Beswarup will subsequently join and present their cases. So thank you all for joining, and I request Dr. Abhishek to start with his case.
Thank you, sir. Good evening, everyone.
Good evening. You can share your screen, Dr. Abhishek.
Sir. Is my screen visible, sir?
Yes.
Yes, it is in editing mode. You can put it on slideshow mode.
Is it okay now?
Yes.
So good evening, everyone. I'll be presenting a boy who had been referred to us from the ENT department, as he had gone there with history of hearing loss. So we have a boy who is right-handed, resident of Chandigarh. He's the firstborn of non-consanguineous marriage, and he was referred from ENT for neurological evaluation, where he had presented with chief complaints of hearing loss. Here, he gave his parents gave history of progressive difficulty in walking, which was noted since 5 years of age. He was symptomatic since around 2.5 years of age, last years. So till 5 years, he had attained all his milestones as per his peers, and the parents didn't notice any difference from the others. However, as he advanced, he started having difficulty in school in climbing stairs, and that the teachers just started telling the parents that आप अपने बच्चे को first floor पे class है तो उसको छोड़ के जाया कीजिए वरना वो school में late हो जाता है. So this is what the first thing started. Then he never used to participate in sports. He used to take long time to reach his class. He used to jump earlier, but he stopped jumping. He could no longer jump, hop. Also, running slowly stopped. He could not dress or undress on his own. He cannot raise his hands to comb hair or brush his teeth. He cannot squat in a controlled manner, and he finds it extremely difficult to get up from a squatting position, and completely started depending on parents to take baths, to clean himself after the washroom. And he would no longer gain much weight, and he started becoming very lean. The parents also noticed that there is difference in strength in both sides. His left arm was weaker and right leg was weaker. They also noticed that he takes a lot of time to eat and he prefers to have soft mashed food. He was having difficulty in drinking juice via a straw. It took a lot of time. He never could blow candles or blow balloons. And at night, he used to keep his eyes slightly open. They also complained that he had very weak cough. He could not cough effectively. And even while trying to clean his nose, it took a lot of time, and he never used to clean his nose properly. He doesn't expectorate effectively, and he has a very weak cough. And on retrospect, they do remember that he used to cry less as a neonate compared to his younger brother, who is around 2.5 years of age now. However, there was no difficulty in feeding. He also complains of occasional aches and pains, especially in the lower limbs. And as I reported earlier, that he primarily had presented to the ENT department for hearing loss when the neighbors started complaining that he doesn't respond to when he used to be called, and they had to raise his voice to call him. Now, there was no history of any fluctuations or easy fatigability. There is no history of any drooping of eyelids, double vision. He did not complain of double vision. There was no squint noted by the parents. There was no history of recurrent pneumonias for which he required admission apart from usual cough coryza which children get. He did not have any history of a disturbed sleep, no headaches, headaches. He did not give any history of loss of sensations or abnormal sweating. There were no rash, joint pains or cramps, no breathing difficulty, chest pains, no deformities noted by the parents. There were no history of seizure, cognitive decline. Mother did not give any history of suggestive of myotonia, any diabetes operated for cataract or any frontal baldness. There was no history of hand tremors or lingual tremors in the child, and there's no history of tightness in the limbs noted. There was no forthcoming history of similar illness in the family. So we went on to examining the child. He stood at 1.5 centimeters, which is minus 1.8 Z score, and a weight of 16.5 kgs. He was normocephalic. On first examination, we could see that he is lean, he is thin built, and he has predominant lordosis is present. This is his usual self. And when we told him to close his eyes, he could not close his eyes completely, and which is asymmetrical. The left eye he is closing much less than the right eye. This is when we told him to smile, and we can see that he has a horizontal kind of smile and there is dimpling present. This is the video in which he is unable to blow. When I asked him to blow, he was unable to do that. On examination, there was no dysmorphism, no neurocutaneous markers, there was no rash present. He had low volume speech. There were no tongue fasciculations or hypertrophy. There was no polymini myoclonus, and there were no palpable nerves. However, he was noted to have high arched palate. This is his picture from behind, and we can see definitely that on the first look, we can see that there is scapular winging present, though there is no overriding of this scapula present. Both bilateral scapular winging is present, probably much more visible in the right side. His proximal limbs appear to be thinner compared to the distal limbs, and even the calf appears to be preserved when compared to the thighs. This is his video when we asked him to raise his hands. He was having extreme difficulty in raising hands. And we can see that the right hand he could raise a little easier compared to the left hand. This is when we told him to walk. We wanted to look at his gait. Now, please note that he is having foot drop bilaterally. He is having a lurching gait, and his hands are. And we could also note that on calling him multiple times, he looked back to us, and that is when obvious hearing deficit was also there. On examination of his hand muscles, they appear to be preserved. On examination at the axilla, we can see that there are two axillary folds, and the angle of the axilla is not exactly horizontal, but slightly slanting. This is when we asked him to climb the stairs. He was having a lot of difficulty in climbing stairs. We had to be careful with him. This was interesting. We wanted to look for Beaver's sign, and this is when he's lying down without any effort, and this is when we told him to flex his neck. He had prominent neck flexor weakness, but to our surprise, we noted that his umbilicus is stretched downwards. I was expecting that it will be moving upwards. So he had a reverse beaver sign. This is when, so notice how the umbilicus moves down. Playing the video again. So this is reverse beaver sign. He had proximal muscle weakness. He had weak neck flexors. Extensors were slightly better than flexors. He had shoulder weakness predominantly. However, the wrists were okay, were normal, around 4/5. He had foot drop. The reflexes, there was hyporeflexia in the upper limbs. The lower limb reflexes were preserved. Now, this is the overall picture in which we can see that he had neck flexor weakness. He had wasting, winging of scapula. The biceps and triceps were wasted. He had forearm muscles were spared. He had truncal weakness. There was reverse beaver sign present. He had wasting of the thighs. The calf was spared. He did not have any hypertrophy. There was foot drop and there was no sensory involvement. He had SNHL and he had a prominent lordotic posture. So the clinical summary, a 7 years boy with significant facial weakness, shoulder girdle involvement with scapular asymmetric proximal upper limb weakness with beaver sign, with pelvic girdle weakness and foot drop. His extraocular muscles were spared and there was no ptosis. His sensory system was spared and he had symptomatic hearing loss. So we kept a clinical possibilities of, we wanted to keep treatable causes first, riboflavinopathies, BVVL, limb girdle myasthenia. However, there were a few pointers against it. FSHD was a possibility in view of asymmetric faces, predominant facial muscle weakness. Congenital myopathies we kept as a possibility. LGMDs and mitochondrial myopathies. So we sent baseline investigations. His CKNAC was 2,700. AST-LTs was slightly raised. His NCS showed reduced CMAPs in bilateral peroneals. He had bilateral SNHL on hearing evaluation. His fundus was normal. His pulmonary functions test reported mild restrictive lung pathology. His ECG and echo were normal. We went on to examine the father and the mother. Mother did not have any signs, and we can see the father having asymmetric shoulder weakness, in which we can see the lumps and bumps on the left shoulder, and he had subtle difficulty in raising the left limb. He also had mild weakness in closing the left eye. In this, we can see scapular winging in the father in the left arm. So we went ahead. First, we wanted to rule out treatable things. We sent a whole exome, which turned out to be negative. And then we sent D4Z4 repeats, which came out to be positive. He had contracted D4Z4 repeats, less than 10. So we made a final diagnosis of FSHD, probably infantile onset. Should I stop here?
Yeah, Dr. Renu, if you want to discuss few differentials and clinical things, you can at this point.
So thank you, Dr. Abhishek, for very well presenting the case and showing the classical signs. This patient has several of the classical signs which FSHD tend to have, like scapular winging, overriding of the scapula, and a smile which is known as which is like a horizontal smile with dimples which are laterally present, and it is like has some resemblance to a smile of a facies of a tapir, which is like a mammal, which is looks like a pig, where there's upper part of the face or upper lip is kind of protruded anteriorly in children with FSHD. And second important sign which we observed is in this patient was beaver sign, which was like a reverse beaver sign in this patient. So, so the initial possibility we consider FSHD, however, treatable condition like BVVL we also considered because of hearing loss as well as weakness, which is limited, particularly more affecting the shoulder girdle as well as the facies. And everything was changed when we examined the father, because initially he did not report to us any kind of weakness, but when we examined the father, we could observe that he had an asymmetric weakness in the shoulder girdle, where his left arm was weak. He could not elevate it to the 90° and beyond. And he has a asymmetric scapular winging and overriding of scapula with this typical Popeye sign kind of, which was not seen in the child because he was very, very weak when he presented to us. And he has also weakness of orbicularis oculi on the left side. So affected father was possibly minimally, but he attributed this to some kind of fall and trauma, which he suffered at 19 to 20 years of age. But he had these weaknesses 19 to 20 years. So I want to emphasize that examination of parent is very, very important. You have to examine them personally. So that's the message this case has, that once you examine, then you definitely had autosomal dominant disorder, which anticipation in the family where the child has more severe weakness and more severely affected. And so there is a message with this patient that, and he has a very severe and early infantile presentation, like his symptom onset was before 5 years. He has hearing loss. Fundus was normal, but infantile onset FSHD is more severe as compared to the adults, which is like around 4 to 20% can have severe infantile onset, and they can be non-ambulatory by adolescents, so they can be wheelchair bound. Otherwise, it's late onset, then usually they are very slowly progressive disease. So I can ask, we can take some questions, and then Abhishek can discuss few points regarding FSHD, which is infantile onset.
So Dr. Khadilkar, sir, any comments?
Yeah, if I may, there are a couple of things that I wanted to say. It's a fantastic case, first of all. It's of course a rare presentation of a disease that you're showing, but since there are students here, in the history and clinical examination, we take anchors and then build stories around them. So in this particular child, you could have proximal weakness as an anchor, and your differential diagnosis will be very wide. You could have scapular winging as an anchor, your differential diagnosis will not be that wide. You could have Beaver sign as an anchor, your differential will shrink further. And when you really look at neuromuscular disease and deafness as an anchor, then it really shrinks. So I just want to make the students aware that amongst the different anchors, you need to decide which anchor probably has the least differential diagnosis and how solid is that anchor. So if you look at hearing loss, then you're really left behind with mitochondrial diseases, riboflavinopathies, an occasional patient with renal tubular acidosis, and FSHD. Then out of these four, then you will weigh one after the other. Add the second anchor, Beaver sign, and then FSHD comes much higher. So this case sort of gives a fantastic opportunity to analyze different anchors and put them in their own merit to reach your prioritization of differential diagnosis. And it's a very rare situation where such a severe deafness and such a severe FSHD appears suddenly, and therefore examination of the family members was so important. And then it really gave you the clue. Thank you.
Thank you, sir. I think very well points you have emphasized. What we have learned that in neuromuscular disease, examination of parents is really revealing. So sometime in a busy OPD, you don't expose them, or you don't take a detailed history, which they just observe, say that it's just a polio happened, or it's just they had a little trauma when they were young. So, but once you examine the patient, it's really changed your, it gives a very clue. Other interesting point, this patient has a reverse Beaver sign. So classically, the Beaver sign in FSHD, which is the highly specific of the diagnosis of FSHD is when there is a flexion of neck and shoulder, and then there is a umbilicus tend to move upwards. This is because of the weakness of rectus abdominis. However, in this patient, it moved downwards. So possibly there was an imbalance here. Upper part of rectus abdominis was much more weaker as compared to the lower part. So that was another interesting feature this has. I could see in the literature 1 or 2 videos has been kind of published in neurology in reverse Beaver sign in FSHD. But this is first time I have seen this reverse kind of Beaver sign. And another point I want to make, that what FSHD we are seeing in pediatrics is usually a very severe phenotype. So in our clinics, what we see is children around 5 to 7 years of age, they have this weakness of shoulder girdle, and they tend to become hyperlordotic very soon. And though it is a rare presentation in neuromuscular clinic in pediatrics, but we do see children with FSHD with very severe kind of presentation. So probably this is because, and we do see family history positive, and some kind of anticipation we do see in the families of FSHD, which is like not very really substantiated in literature, that anticipation do happen in FSHD. But we see very severe presentation of FSHD in the clinic. So, regarding your experience regarding inverse Beaver, how specific and
About Beaver sign, even though we read about it in FSHD and it has been shown to link really with FSHD, there are other dystrophies where you see it. Like it has been shown and documented in the GNE myopathy. It has been shown and documented in occasionally other muscular dystrophies like sarcoglycanopathies and others. So it's not that specific to a disease, but it really tends to the FSHD as a diagnosis. And reverse, I must say, is very rare, and only once or twice I have seen it in FSHD.
thank you, sir.
Thanks.
We can have a few slides regarding discussion if Dr. Gurpreet, if you allow to continue the case.
There is a question in the chat box. What is meant by overriding? You want to take overriding and versus winging? You want to take that? Or you're going to take the chat box later?
I think we can take now only, sir. These clinical
Yeah.
questions are very important.
Along with the cases, we take now only. Now only. Gurpreet, take them now.
Okay. So first we take this question, sir. Overriding of scapula versus winging.
So in this is classical winging, in which we can see that the scapula is visibly separate from the general contour. However, in overriding, we will see the book picture. Our other FSHD children had overriding. This child did not have. So this is like overriding, when you can see the scapula actually visible. In fact, even from the front. So this is the classical overriding of scapula, if I'm correct.
This is because the trapezius lower part becomes very weak, and that's how the scapular stabilizer tend to be very weak. In addition to, like, if you have 4 scapular stabilizer, that is serratus anterior, latissimus dorsi, lower part of trapezius, and rhomboids in the medial. So lower part of trapezius becomes really weak. Hence the scapula on abduction tend to override and can be visible from the anterior. So this is classically seen in FSHD. So other winging is usually displacement toward lateral side. So this is a difference between winging, which is secondary to serratus anterior, or winging, which is seen in LGMD. In FSHD, it's specifically seen that it tend to override during examination on abduction. I think we have a very experienced sir with us, so he can more elaborate on that, why this is seen in.
No, I think what you said is the main thing. If you see it from the front, most likely it will be FSHD. Yeah.
I think we can complete the presentation first, and then we take rest of the questions.
Yeah.
Are there any other slides?
Just few more, sir. So this is the classical signs which we can see in the first two has already been discussed. This sign, the horizontal smile and the puckering of lips, we saw in our child. And this is the polyhill sign, which is seen. We should know what are these hills and valleys signify. So first arrow signifies wasting of the trapezius. The second is the second hill is the superior angle of the scapula. The third hill is the displaced acromioclavicular joint. The fourth valley is the atrophied proximal deltoid, and the fifth is the normal bulk. So the distal deltoid is spared. This hyperlordosis is predominantly seen in infantile FSHDs. And this is the classical Popeye sailor sign, in which the proximal muscles of the upper arm are very thinned. However, the distal forearms are spared, which is seen in FSHD. This is the signs in gist, and there are few extramuscular manifestations which can point towards FSHD. Like in this case, hearing loss was there, We can see retinal diseases, which can be seen more prominently in infantile FSHDs. We can have cardiac arrhythmias, cognitive impairment, and seizures as a part of the disease complex. So just one slide on infantile FSHDs is more severe, and it is a rapidly progressive form. He progressed in 2 years. The onset of facial weakness before 5 years and onset of shoulder girdle weakness before 10 years should point us towards infantile FSHD. SNHL and retinal vasculopathy is common. They can have a fraction of them can have seizures and cognitive disabilities. However, cardiac and respiratory complications are rare. A word of point is infantile FSHDs can be sporadic also, while FSHD is more commonly autosomal dominant. Their hyperlordosis is known, and many of them lose ambulation early and become wheelchair dependent. One slide on genetics and pathophysiology. So this is a normal human, person who has DUX4 gene, which is repressed. So this is a normal. The red shows that the DUX4 gene is repressed. It is not manifested. Now, FSHD happens when there is de-repression of the suppressed DUX4. So it is sort of gain of function. So this is how it is separate, different from other muscular dystrophies in which we have loss of functions like suppose DMDs. We have loss of dystrophin. We do not have that. SMA, we do not have the SMN protein. But in this case, this DUX protein results in formation of a protein which is toxic to the muscle fibers. And this is where actually the therapeutic things come in, that if in some way we can stop the production of this DUX4 protein, which is toxic to the muscle fibers, and other cascades downgoing, like inflammatory cascades and disrupted myogenesis. So there is a window for therapy. So the current therapies are basically physical therapy, exercise, orthopedic intervention, pain management. This child had a lot of pain issues, respiratory surveillance, yearly pulmonary function tests, ophthalmic evaluation, and obviously intervening for the hearing loss. So these are the steps where all the steps are basically to stop the production of DUX4 protein.
Bit fast because other 4
Finished,
presenters.
sir. It's done. Last slide, sir. It is some of them can become wheelchair dependent, and genetic counseling is extremely important. These were my references. Thank you, sir.
Yeah, so I'll take a few quick questions. Differential diagnosis of Beaver was discussed by sir, I think. Any comments, Dr. Ring? Any other differentials of Beaver?
So already has told, sometime it can be seen in amyotrophic lateral sclerosis. Focal presentation of FSHD can also have this presentation. And other is can be seen in LGMD, and GNE myopathy has been said that it is almost present in 100% cases.
Okay.
Recent literature I could see.
And where did you send D4Z4 repeats? Somebody has asked.
This test is commercially available, but it is very expensive commercially. So, but we this got in some research.
Okay.
Study.
We'll take other questions later on because they are not related to this case. So now I request Dr. Anaita Hegde and Dr. Ruta Dio to present her case. And I thank Dr. Anaita and everyone to agree on such a short notice. So kindly share your screen, Dr. Ruta.
Thank you, Dr. Abhishek, for presenting wonderful case.
Good evening, everyone. Sir, can you see my screen?
Yes, we can see you.
Good evening, everyone. My name is Dr. Ruta. I am a second-year fellow in pediatric neurology under Dr. Anaita Hegde, and we present a case from SRCC Children's Hospital, Mumbai. The case is of a patient with a myasthenic phenotype and the dilemma we had in his diagnosis. He was an 8-year-old boy, first child of a non-consanguineous marriage, resident of Maharashtra, from low socioeconomic class, and his father complained that he has drooping of eyelids since 2 years of age. At 2 years, after or around an acute febrile illness, the child was unable to lift both his eyelids up completely, and the parents thought that this could be related to the illness and that it would recover by itself. At 3 years, they noticed that he was constantly looking up while he was running, talking, or even writing, and he would sometimes stumble due to the eyelids covering his upper eyeball. Now the eyelids had started interfering in his everyday life, and they took him to a pediatrician who started on some calcium supplements. There was no response to the medication at this point. At 4 years, the boy complained of heaviness in both his eyes, and this complaint would be absent when he woke up, and it would reappear as the day went by. There was no history of any delayed motor milestones, weakness of other limb muscles, or any progressive deterioration of achieved motor function. There was no history where he would suddenly start sweating, or any history of regression after other febrile illnesses. He had a normal perinatal and developmental history was age appropriate. So in view of a 2-year-old boy who came with ptosis onset at 2 years, which was bilateral and interfering with his everyday life, and there was diurnal variation, we suspected that this was a myasthenic phenotype, most likely an acquired variant. He came to us for the first time at 4.5 years, where he was conscious, he was responding to oral commands. He was a well-appearing child. His vitals were stable and no heart rate or BP fluctuations were noted. No other systemic abnormalities were seen. And on general and neurological examination, only bilateral ptosis was present. Rest of the extraocular muscles were complete, and a cranial nerve examination was also normal. Motor examination was normal with reflexes 2+ in all 4 limbs. On fatigability, the muscles of his eyelids were fatigable. The child was too young to perform the Cogan's test, or he was unable to understand the command we were trying to give him. Cogan's lid twitch sign is a brief twitch of the eyelid as it returns, as it overshoots, and as the eye returns to a primary position after prolonged down gaze. The patient was first seen by us in a rural camp setting, and we could not procure an ice pack to perform an ice pack test on him. He came to us with the investigations which were previously done on him, which said that the biochemistry with all his liver enzymes were normal, his CPK and muscle enzymes were normal, and EMG NCV with RNS was done on him, which was normal. However, the ocular muscles were not tested during this examination, and autoimmune antibodies to acetylcholine receptors and MuSK antibodies were negative. So based on this, our differentials were an acquired myasthenia gravis, a congenital myasthenia, some form of a congenital myopathy, or a metabolic myopathy. The features favoring an acquired myasthenia were that it was an acquired ptosis with fatigability in a child with otherwise normal development and normal neurological examination. However, the age of onset was 2 years, which is very young for a child to have an acquired myasthenia. His antibodies and RNS were negative on examination. For congenital myasthenia, we wondered if the parents could just have noticed the ptosis in and around the febrile illness at 2 years, and actually there was the ptosis which was present at birth. However, there was no other history of any perinatal or infantile weakness, and he had an absolutely normal development on history and examination. There was a definite weakness of the orbital muscles. However, there was no hypotonia, his reflexes were normal, and his EMG and CPK were also normal. So we thought that this was less likely to be a congenital myopathy. However, these findings can be seen in patients very early in the disease process. And because the ptosis had started in a fever-provoked setting, we thought that this could be a metabolic myopathy and the patient must have decompensated in some way, resulting in the ptosis. But there was no regression with any other stressors or any other febrile illnesses through the 4.5 years. And his biochemistry with all the enzymes was absolutely normal. So based on these differentials, we considered that the myasthenia phenotype was the most likely diagnosis, but it was important to differentiate congenital from an acquired myasthenia. We would have liked to start him on pyridostigmine if it were an acquired myasthenia. However, we know that even though there are some genes in congenital myasthenia where we do get benefit with pyridostigmine, there are significant genes which actually cause worsening with pyridostigmine. And since we had seen this patient in a rural setting, it was very difficult for us to confidently start pyridostigmine without differentiating between the two. So we asked the parents for old photographs of him. This is him at a few months of age. This is him on his first birthday. Both these pictures very clearly show that there is no ptosis in either of them. And the pictures which came subsequently at 2.5 and 4 years show that the child has bilateral ptosis. So based on this, a diagnosis of an acquired myasthenia was made, and he was given a trial of pyridostigmine started at 0.5 mg per kg because we were in a rural camp and we weren't sure how he would respond. And our diagnosis was based on the clinical examination and the 2 photographs that we got from his past. But he improved, and we increased the dose to up to 5 mg per kg over 2 years. The immediate response was that the complaint of heaviness of both his eyelids completely disappeared. His ptosis got better and it did not now interfere in his daily activities, but it never went back to normal and it still persisted. Unfortunately for us and him, the COVID pandemic hit. We could no longer go back to camp and we did not have a follow-up on him for the next 2 years. When we went back 2 years later, we found out that the parents had stopped the medication 3 to 6 months prior to coming to the camp due to unavailability of the medication in the village that they stay in. And during these 3 to 6 months, they also noticed that he was walking slower than the other kids. He could go to school properly, but on his way back, he was very tired and he was finding it difficult to carry his school bag. He was finding it very difficult to chew and he was taking longer time to finish his food now. He had difficulty in seeing the board in the classroom and complained of double vision. His writing also became a little slow. However, his speech volume and clarity were always normal. So when he followed up, we restarted him on pyridostigmine and told them that we need to evaluate him further, and we asked them to follow up in Mumbai, which they did 6 months later. When he came back to us in Mumbai, we did an autoantibody evaluation, which was still negative. We repeated an RNS, which was negative. Unfortunately for us, he had taken his morning dose of pyridostigmine at 6 a.m. before he came to us. And then the parents insisted that they wanted to go back the same day because of concerns. So then we did him the last of the day at 8 hours after his last dose of pyridostigmine. This included his ocular muscles and his limb muscles, and the RNS was still negative. We tried to do a single fiber EMG on him, but he was very uncooperative for the same. An MRI brain was done in the 2 years before this, which was normal, and an HRCT chest showed no thymoma, and he had a normal size of thymus for his age. So based on the differentials that we first considered, and we never had a positive finding other than the clinical examination, we sent his genetics to rule out the other differentials. The patient came back to us 1 month later with the genetic report, which said that he was heterozygous for the selenon gene. The autosomal dominant phenotype of the selenon gene was the congenital fiber type disproportion, which had a neuromuscular phenotype, of which he met the facial muscle weakness, the ptosis, the neck muscle weakness, walking difficulty, easy fatigability. He had an onset in childhood and his disease was now slowly progressing, but he was still ambulatory. However, he never had myopathic facies, never had respiratory involvement or hypotonia. His motor development was absolutely normal and his reflexes were preserved even 6 years after the disease onset. So we sent out parental segregation and it turned out to be heterozygous positive in his father. His father is a 42-year-old male, asymptomatic till now with no weaknesses. He says that he can carry the same amount of weight that he used to. He could walk the same amount of distance and there was no any wasting or any reduction in size of his upper limb or lower limb as compared to before. While genetics does help us in many situations where we do get the diagnosis, here actually we thought that this was not a very significant detection and that genetics was actually negative for him. And based on this, we considered that the diagnosis of acquired myasthenia was more likely. We came across these clinical criteria by the Japanese group in 2022. And when we tried to evaluate him based on these, he had symptoms of blepharotosis, eye movement disorder, facial muscle weakness, mastication disorder, cervical muscle weakness, and limb muscle weakness. He still had a positive fatigability. However, the rest of them could not be performed. So based on this, we had one from the symptoms, we had one from the neuromuscular junction disorder, and we had ruled out the other differentials based on the genetic report. And we thought that a definite diagnosis of acquired myasthenia gravis can be made. So this was a child with ptosis, fatigability, with ocular and generalized symptoms. His RNS was negative on pyridostigmine, unfortunately, and single fiber EMG was not possible on him, and we had ruled out the other causes. When the patient came back, he had again partially responded to pyridostigmine in form of improvement of ptosis and some improvement in his generalized symptoms. So based on the treatment protocol for acquired myasthenia, we started him on oral prednisolone at 0.8 8 mg per kg per day, we gradually increased it, and this was the dose at which we got the best benefit. He was now walking to school, carrying his school bag by himself. His diplopia resolved, chewing like previously normal, and his handwriting became better, and he could write at the speed of his other classmates. He still has a minimal ptosis, but it is now above the pupillary line, and it does not bother his day-to-day activities. There was no further progression of the weakness or any other autonomic symptoms noted, and there was no regression of his other achieved milestones. Both the parents and the child are very happy with the improvements, because other than the minimal ptosis, he actually did not have any further concerns. So based on this, we reached out to this treatment algorithm, where when he first presented to us, he had mild symptoms. We started him on pyridostigmine, and he did show clinical improvement. However, because of the COVID pandemic, we lost him for follow-up. And then when he presented to us the second time, he had moderate to severe symptoms. We started him on pyridostigmine and corticosteroids once we were sure about the diagnosis. And then once, now that he has shown benefit on corticosteroid, we do plan to wean off the pyridostigmine and to continue the lowest possible dose of steroid to maintain him in the current state without any complaints. So the differentials that we first considered, the congenital myasthenia gravis and metabolic myopathy, we could rule out based on the genetics and the other symptoms. The congenital myopathy, even though we ruled it out based on the genetics, it is still known based on the literature review that there is no significant variation in penetrance or no significant difference in the severity of the presentation with the selenon related gene. But since genetics is an ever expanding branch, we do not know if this might become significant in the future. So based on this, our diagnosis of an acquired myasthenia was made based on bilateral ptosis, fatigability, diurnal variation, his response to pyridostigmine, and further improvement on oral prednisolone. However, he still was antibody negative despite being 6 years of the disease process. We also know that for a patient with generalized myasthenia, acetylcholine receptor antibodies are positive only in 80% of the patients, while for the MuSK antibodies are positive in the other 5 to 7% of the remaining patients. No, meaning that 10 to 15% patients remain seronegative throughout the entire process of their disease. Seroconversion is usually seen at 6 months to 5 years after the symptom onset in a patient with prepubertal onset of symptoms. But because he is still in the prepubertal age, we think that he might become positive in the future, and that the antibody negative for now would change depending on how he progresses in the future. The other concern was that his RNS was also negative despite being done twice, and but we were not sure whether this negative this time was a true negative or was it a drug-induced negative. We also know that RNS sensitivity, though higher in patients with generalized disease of 71% and than pure ocular myasthenia, which is around 38%, it also means that 30% of patients with generalized myasthenia actually are RNS negative. So based on this, we considered that this is a patient, to conclude, this is a patient with a myasthenic phenotype with onset at 2 years of age, who presented initially as ocular myasthenia, then later on progressed to generalized myasthenia, who responded very well to acetylcholinesterase inhibitors and oral steroids, who is seronegative, but he is still prepubertal, and his RNS negative even 6 years into the disease process. So in future, we plan to repeat his RNS by keeping him off pyridostigmine for another 24 to 48 hours. And we also plan to do a single fiber EMG on him. We know that the sensitivity of single fiber EMG is 95%, and it may increase to up to 99% if 2 affected muscles are sampled. So we have planned to do it in the orbicularis and the frontalis muscles. If this comes positive, our diagnosis will be confirmed, and if there are any further deterioration or relapses of the disease, we might consider a thymectomy on him or some other form of steroid-sparing immunomodulation. However, if it is negative, I would like to ask the respected panelists, what should we consider next, and what other differentials do you think we should consider in a patient who would present like this? With that, I would like to open the panel for questions.
Thank you, Dr. Ruta. Very well presented, and discussion was really very good. I would request Dr. Naita for the comments, and just one or two questions from me, that when to add steroids, and secondly, what should be the duration of pyridostigmine and steroids in general in these cases?
So, thank you, Gurpreet, for giving us this opportunity. Unfortunately, because of the short time, we couldn't get all the videos and everything ready. We chose this case because he was a dilemma in diagnosis, and we had to go one step, one after the other, to try and rule out everything that could be an additional etiology. Even at the end of the day today, there is a little doubt inside whether it is exactly just this acquired myasthenia or could we be missing. But once the genetic came, it sort of ruled out most of the things we had. To answer your question, the addition of steroids, once you know you have it, you have a myasthenia, I think after you've started the pyridostigmine, so that there are two. I think there are no confirmed protocols which are there. There are two that say if it's mild type pyridostigmine, then you add the steroids if necessary. There are those who say if it's moderate to severe, you can start with pyridostigmine and steroids simultaneously if necessary. You try not to keep the pyridostigmine on for too long, for many years, and you try to keep the steroid on a very low dose, preferably as little as 5 milligrams a day or 5 milligrams alternate day, which may continue for about a year or two. If he goes into remission, very good. If he doesn't go into remission with that, you may consider steroid-sparing immunomodulating medication. My concerns here was, I would like to really ask Dr. Khadilkar over here. Sir, given that...
Dr. Khadilkar had to leave early, so he's not there, I think.
Okay, so I just wanted to ask, and I'm happy to hear the experience of others. Yes, the pyridostigmine ideally should be taken off before you do a repetitive nerve stimulation. Ideally, 12 to 24 hours is the required time. Second is single fiber will almost definitely give us a diagnosis, confirmatory or not. However, I have no other differential diagnosis on this child after this, and I think we've ruled out everything, but I would love to hear from y'all, in fact, if there's anything else y'all could have thought or considered for this child.
Yeah, I would ask other panelists if we can add to it. Dr. Renu, Dr. Prashant, Dr. Raju, anyone, Dr. Rashmi.
Just hello.
Hi, Dr. Rashmi.
Naita. I was just wondering, would there be at any stage a role for IVIG in such a patient who is not responding to very well to steroids?
So be honest, the minute we put steroids, he's responded beautifully. So
Okay.
at the moment, the concern is not the response to the thing. He's responded well with pyridostigmine, and he's responded really well with the steroids. Parents are happy, he's back to school, he's running, he's climbing stairs, he's doing everything perfectly. My concern is still with the proof of the diagnosis. And if you see that last chart, you can have as many clinical features as you need. I don't have antibody features positive. In the neuromuscular junction, I only have the fatigability at the given moment, but I think once we repeat the third time RNS and the single fiber, we should get the confirmation of the diagnosis. My only concern is I could not consider a thymectomy, and I cannot consider immune modulation drugs in a child where I feel I have not got confirmatory proof of the diagnosis. I would like to hear suppose he relapses tomorrow. Ruta, can you put the questions up again? Suppose he has to relapse tomorrow. Suppose he worsens over a period of time. My concern is how aggressive can I be in his treatment? If you had antibodies persistently negative, if you have RNS persistently negative, and there is a solid 10 to 15% who can be RNS persistently negative, and a 10 to 15 who can be antibody persistently negative, would you be comfortable ever thinking of immune modulation or thymectomy?
I think Anita, Lokesh here. I think we definitely will be comfortable going ahead with mycophenolate and those kind of medications if they are worsening or the steroid is showing its side effects because of the dosage or the duration. Definitely, it's going to be beneficial because pre-pubertal there is always a challenge because the chance of you are getting a antibody positivity is low. and RNST, as you have experienced twice, sometimes it can be negative. But you have ruled out most of the things. There is diurnal variation. It's suggesting the clear response to pyridostigmine is also there. I think you have enough clinical evidence here to go ahead with immunomodulation, and we have done in a few cases like this, exactly similar course of illness actually in some of them.
Okay, thank you.
Ma'am, I want to add here.
Sure.
So if the clinical phenotype is consistent with myasthenia, we will go ahead with the immunomodulation further, like rituximab or thymectomy in these cases. I agree that RNS is tricky in children. It can be negative. Doing a facial and orbicularis oculi RNS is a problem. And another point would be that cell-based assay rather than ELISA, like ACHR and MUSC are based on ELISA, immunofluorescence, and cell-based assay. So the literature says the cell-based assay has a higher sensitivity for diagnosis of MUSC and ACHR, and some of these double seronegative myasthenia can have antibody positive for LRP4. So this has come from Dr. Siddharth, who is in Oxford. They have developed this assay, cell-based assay for LRP4 as well as MUSC and ACHR. So it is done in research basis, but can be done in such cases who are like double seronegative, and you think and you strongly feel they are immune responsive because your response to steroid pyridostigmine is gratifying in such cases, and it is supposed that he will be in a long-term steroid. So then these tests can be done in further.
Yeah, I agree. We have reviewed that and looked that up, largely more for MUSC. I think the percentage in children with MUSC is relatively smaller. But I do agree. Yes, I've seen Bisvaroop is written. We routinely do use rituximab as our drug, but I prefer rituximab really than mycophenolate in children who have resistant or difficult myasthenia. But at the moment, touch wood, he's responded very well. So I'm not looking at any treatment options. I'm just thinking, in case I persistently say negative, how comfortable are we to go ahead with more aggressive treatment?
Dr. Naita, even we would, Lokesh was mentioning, go ahead with the immunomodulating drugs. And as Bishru was written, we do rituximab routinely.
So since I have all of you all out, how comfortable are you all with thymectomies in children who are antibody negative? And the ones that I do quite a few of thymectomies of our patients, and invariably, even if the size of the thymus looks normal on the CT scan, on histopathology, invariably they'll come as thymus hyperplasia. So you may not have a thymoma on your CT scan. So you don't fall into the thymoma generalized myasthenia category. You fall into the what looks like a normal thymus. But if you do remove it, even in those who are antibody negative, we have found very good results. Histopathology showing hyperplasia and clinically child showing improvement. So
Dr. Veda has joined, I think.
Yeah.
Dr. Veda?
Yeah, can you hear me now?
Yes, sir.
Well, that's a wonderful presentation. So if I had seen this child in the first instance, it can be challenging. And usually what I use is also albuterol. It's a good one, and it's safe in those conditions where you can get hypercholinergic sort of states, where you're worried about collagen, collagenopathy, which causes the acetylcholine end receptor esterase deficiency. That's one, and slow channel syndromes. But you can get around it with using albuterol. Usually, I would use like about 2 milligrams, or not sort of titrated. Usually 2 to 3 times. That's one. Number two, in this child, in general, as far as thymectomy goes, there's really no data to support in prepubertal children. And I would avoid it because there's always this concern, how is it going to modify the immune response? And so that I would be very careful until at least they achieve puberty. Now, this child could very well fit into a LRP4, and LRP4 usually is will present with purely ocular eye trouble, and also leading to more trouble with the limb muscle. So LRP in this child is distinctly possible. And the child has responded, and that's usually the LRP will respond very easily for a low dose steroids. I have both kids and few adults who I can control them in less than 10 milligram dose. And as far as the question about combining pyridostigmine with steroids, I see really no problems. I use pyridostigmine freely. Really, there's really no problems using it. The concept of hypercholinergic state is very, very uncommon. It's only would happen in muscle disease who are over medicated with pyridostigmine, which you shouldn't. Usually, if you're MuSK positive, you shouldn't really use Mastinon in that setting. You can get into trouble there. Or in the setting of syndromes where there is overactivity at the postsynaptic membrane level, which is acetylcholinesterase deficiency states, slow channel syndromes. So those would rarely. One of the things that you can look for these two conditions when you do your EMG is to do what's called as look for repetitive motor response. So if you do a simple in a weak muscle, you do a single CMAP recording, you will see multiple little wavelets would come up. And that correlates roughly with how much weakness is present. And lastly, in this child, I probably would keep him on a very low dose of prednisone and see if you can bring it down to less than 10 milligrams, then you're okay. But I would really be very careful about using others like Rituxan, especially if he's doing well. Now, one comment about the repetitive nerve stimulation is it has to be done on a muscle that is clinically weak. So if you had a child who has, say, trunk weakness, if you did it on the hand muscle and said that that was normal, it really doesn't mean it's normal. You have to try and do it on, say, the trapezius, or sometimes you may have to do it on deltoid. And it can be tricky. And some of those patients, I would do them with help of anesthesia under sedation, because it can be difficult to stimulate proximal muscles. But otherwise, I would continue in observing, and it'd be interesting. LRP is still a distinct possibility.
Thank you. Thank you very much.
Yeah.
Thank you, Dr. Veda, for your calls, and thanks, Dr. Anayatha. It was really a very wonderful presentation, Dr. Rutha, and a great discussion.
Thank you, sir.
So brace up for being awake. There are still 2 more cases left. So shall
Gurpreet, question if you are having it relevant to the case, please take it.
There were 3 questions. Dr. Rutha is giving an online answer. So how long to give immunosuppression in acquired myasthenia gravis? Should be a duration.
I usually go by clinical response. If I just try to, I usually tell my folks that when you put them on immunosuppression for immunological disease, it's like walking on a hilltop where you don't know where the cliff is going to fall off. So the best way to find this, when you're high, you bring it down faster. And then when you're getting close to, say, like 5 or 2.5 milligrams, you don't make a change, like once every 6 months or so. Some of them, you may continue 2-3 years because that little bit of dose may be enough to keep them from getting a clinical picture without having significant problems from side effects. So I would keep them consistently for a longer period of time, especially if they're less than, say, 10 or milligrams daily dose.
So so what was the pointer in this case which led to investigate for the genetic cause? So should we do genetics in all cases of myasthenia in children? So in another way?
Many times we end up doing it because it can be tricky. One thing that this kid, initially I was concerned was whether this could be a CPEO phenotype of mitochondrial disease. You have bilateral ptosis, and it can be variable amount of symmetric eye movement weakness. But of course, he responded well. But initially, when SCM comes up, we should evaluate for mitochondrial disease as well.
Thank you, sir. There are no more questions for this case. So we move ahead with the third case. The moderator will be Dr. Vaikunta Raju from Indira Gandhi Institute of Child Health, and Dr. Vikas will be presenting the case. Dr. Vikas, please share your screen. So Vikas is there. Oh, yeah.
Good evening, sir. Am I audible?
Yes, you're audible.
First of all, I want to thank all the professors and senior faculty on the platform for giving me an opportunity to present the case. Yeah.
Thank
you. Good evening, everyone. Today, I would like to present a rare case of proximal muscle weakness with the red-like phenotype. I'm Dr. Vikas from Indira Gandhi Institute of Child Health. My moderator being Dr. Vaikunta Raju. This was a 12-year-old female hailing from Bangalore, with informant being the mother. Presented to us with complaints of delayed developmental milestones since birth, and behavioral abnormality started around 2 years of age, and also had complaints of difficulty in getting up from sitting position around 2.5 years of age. So, starting with the birth history, antenatal period was fairly normal with the regular antenatal checkups. With the mother started quickening at 5 months of age. She appreciated fetal movements well with the normal antenatal scans. Birth history: baby was born at term, LACS because of a previous LACS. A baby was born by a vertex presentation, was 2.9 kgs at birth, with good cry after birth and no issues per se at birth. She did not have any feeding issues. There was no abnormal breathing pattern, and the child was comfortably discharged at day 4 of life. So, coming to the developmental milestones, gross motors, the child started neck holding by around 8 months. She was able to roll over by 1 year. She started sitting independently around 1.5 years of age. She started pull to sit with around 2 years of age, but she had few difficulties in doing that. And she also started walking without support by 3.5 years of age. She climbed stairs only with support by around 6 to 7 years of age, was never able to run. She started reaching out for object by 6 months. Mature pincer grasp was there by around 1 year. She started feeding self with spillage by 2 years of age. However, she was never able to dress or undress independently, but unbutton she was able to do with difficulty. She was also able to scribble occasionally and occasionally draw circles as well. She started cooing by 6 months, speaking syllables by around 1 year. By 2 years, she was able to speak few meaningful words, and by 5 to 6 years, she was speaking 2 to 3 word phrases. Currently, she is only able to speak complete sentences but reduced clarity. She started having social smile by 4 months. She started recognizing mother by around 8 months. She could wave bye-bye by 1.5 years of age. Bowel and bladder control attained by 3.5 years of age. She was able to follow one-step command by 4 years. Currently, she goes to special school, follows a 3-step command. However, all these milestones were inconsistent, and she was also on regular rehabilitation, started around 2 to 3 years of age. So, coming to the brief of my developmental history, she had a global developmental delay, motor milestones being affected more than the cognitive milestones. So, coming to the history of presenting illness, as I mentioned earlier, she had difficulty in standing up from sitting position that she always used to get up with support since the moment she started standing. She also had a difficulty in getting up and sitting from supine position in the form that she used to turn towards one side always and then get up. And gradually, parents also noticed that child was always walking slowly with an abnormal gait. By the history they have given, it seemed to be a waddling gait, but she was never able to run, but climbed stairs with difficulty. These symptoms were insidious onset, gradually progressive, and the weakness from the onset to current age is worsening throughout the course. She also had difficulty in raising hand above the head and needed assistance in changing clothes and combing hair. However, she was able to do her fine motor activities well, like breaking rotis, mixing food normally. She was able to scribble, and she also did not have any difficulty in gripping slippers. There were no complaints of ptosis, diplopia, difficulty in swallowing, chewing food, reduction in facial expression, or no change in voice, indicating a fairly normal cranial nerves. There was no diagonal variation of this weakness. There was no worsening during exercise. There was no worsening during stress or febrile illness. There was no history of any per se atrophy or hypertrophy of the muscle. There was no contractures or deformities noted at examination. There was no history of any sensory disturbance, no history of any seizures. Also, one peculiar feature what parents complained was she always had a dry and rough skin and always used to have the itchy skin. So behavioral abnormality started around 2.5 years of age in the form that the child had reduced interaction with people. She always used to indulge in self-play. She had stereotypic behavior. She also had poor eye contact, persisting mouthing behavior, and reduced attention span. This was a brief about the workup which she had undergone from past 8 to 9 years. 2016, one workup was there for the same complaints where fairly preserved ammonia lactate and with a mild abnormality in EEG, with the PET CT showing hypometabolic areas in cerebral and temporal lobes. EMG had a myopathy reported, and echo was, however, normal. Muscle MRI at that time showed atrophy of limb muscles. 2018 had similar complaints for which had also undergone 2 cycles of stem cell transplantation. 2022, with non-improvement of symptoms, he again went to evaluation with fairly similar findings. Family history: she was born out of a third-degree consanguineous married couple without any similar history in the family, no previous abortions. To summarize my history, the child was an 11-year-old child with the global developmental delay involving both motor and cognition, but motor being more than cognition. She also had a progressive proximal muscle weakness, lower limb being affected more than the upper limb. She also had behavioral abnormalities and intellectual disability with autistic features, and few skin changes were there. And she had a normal birth history and a family history. So, an examination, anthropometry, her head size was 49.5, which was around 0 to -1 standard deviation. Weight and height was normal for age, but BMI, she was a bit overweight. As you can see in the picture, the child had exaggerated lumbar lordosis, genu valgum in the lower limbs. And as I mentioned earlier, this was the earlier image shown around 2 to 3 years back, where the child had a thick and hyperpigmented skin. This was there for 2 to 3 years and still persists to have a itchy and a dry skin. So systemic examination, the child had a poor eye contact, reduced interaction, reduced attention span. She also had impaired clarity of speech. She had stereotypic behavior with MMSE being 16, indicating intellectual disability. She also had autistic behavior with a rating scale of 30.5, indicative of moderate autism, which is shown in the video. She's having the repetitive behavior, self-play, indulging, and mild autistic features, as I mentioned in my findings. So her cranial examination were fairly normal. Motor system examination showed a waddling gait. Bulk was bilaterally symmetrical and equal. There was no per se hypertrophy or atrophy on any muscle groups. In the video, as we can see, she walks with a waddling gait and walks slowly, and the behavioral abnormalities, as I mentioned earlier, can be seen in the video as well. So tone, most of she had generalized hypotonia with ankle mild increase in tone in the TA joint. Systemic examination revealed a power of 3/5 in the proximal muscle groups of the upper limb as well as the lower limb, and around 4/5 in the distal muscle groups in the upper limb as well as the lower limb. These are the 2 videos I need to show. This video indicating the truncal weakness. We can clearly see the child has a very gross difficulty in getting up from supine position. And this is a video where she had difficulty in getting up from sitting position as well. So as we can see, she's getting up from with her support of her arms, and she's walking with the knees. And we also noted the child to have a Gower sign, which we can see now. She was only able to get up with the support. So these are the videos which shows progression of the weakness. This was around 2022, where we can see the child fairly comfortably walking, but not normally. Abnormal gait and slowness in walking is noted, which worsened in a period of 1 year, and we can see worsening in the proximal weakness. And this was currently taken, where there is a significant worsening of the weakness, and she's climbing the stairs with difficulty. So examination wise, reflexes, her superficial reflexes were normal. Deep tendon reflexes showed hyporeflexia, and there were no cerebellar signs. Skull and spine examination showed lumbar lordosis with the mild scoliosis towards the right. So summary of my examination: she had a small head, dry skin, exaggerated lumbar lordosis with a waddling gait. She had autistic features, stereotypic behavior, intellectual disability, and examination revealed again progressive quadriparesis, predominantly involving the proximal muscle group than the distal, lower limb being more affected than the upper limb with truncal weakness and hyporeflexia. So with this, I would like to consider 3 differential diagnoses. My first differential diagnosis with the history would be cerebral creatine deficiency, and second one probably a metabolic or a mitochondrial myopathy. Third one, congenital muscular dystrophy. So my points in favor of cerebral creatine deficiency is that the child had autistic features, intellectual disability, global developmental delay, and myopathic features. However, there were no any extrapyramidal signs indicated by the mother or found on examination, which is against cerebral creatine deficiency. Otherwise, most of the points favor cerebral creatine deficiency. Mitochondrial myopathy, again, the child had a multi-axial involvement with the LMN and UMN both being involved, with intellectual disability and myopathy. And points against mitochondrial or metabolic myopathy would be that the child did not have any failure to thrive. There was no episodic acute worsening as seen in metabolic illnesses, and the disease rather had a chronic worsening course. So this was against the metabolic and mitochondrial myopathy. And the congenital muscular dystrophy, again, points in favor were progressive myopathy starting at 1 to 2 years of life, intellectual disability. Against points against was the child was still ambulant at 11 years, whereas the child with most of the congenital muscular dystrophy would have a devastating course, and the child would most of the child were non-ambulatory, and they would have contractures and deformities. Whether our child did not have any of those, and there were no seizures also, which are commonly seen in few muscular dystrophies. For investigation, CBC and inflammatory markers and renal functions were fairly normal. CPK was around 768, mildly elevated, with fairly normal electrolytes. We also found a mildly elevated lactate, which was around 38.6, and MRI, MRS of the brain was normal. TMS we have done was normal, and GCMS was negative for metabolites of creatine deficiency, and echo was, however, done was normal. So this was the MRI, which was again fairly normal. And EG, which was done previously not in our hospital, we found that there was mild abnormalities in the EG, that there was a non-specific spike wave discharge with the mild asymmetric background. And we went ahead with the muscle biopsy, which showed varied muscle fibers with atrophic and hypertrophic fibers on HND staining, and a few endomysial inflammation. This is directing towards a muscular dystrophy, and this was on further staining, special stains. Various stains peculiarly shows central decreased staining and peripheral increased staining, that is the mitochondria being aggregated in the peripheries and absent mitochondria in the center, as we can see in different stains. So this is the central agranular and the peripheral granular thing, which was a peculiar finding. And this is a image showing type 1, type 2 fibers, where there is type 1 and type 2 fibers atrophy. So these typical findings were pointing towards a specific disorder, which is megaconial type of congenital muscular dystrophy, which was a peculiar finding on histopathology. We further went ahead and confirmed the same with whole exome sequencing, which revealed a homozygous pathogenic mutation in the CHKB gene, which was correlating with the phenotype as well as the histopathological finding. So our final diagnosis was a child with global developmental delay, motor more than cognition, with a small head with autistic features, with quadriparesis, proximal more than distal, with the mild regression of milestones, secondary to homozygous CHKB mutation, which is a megaconial type of congenital muscular dystrophy.
Thank you, Dr. Vikas. It was a wonderful case. So, Dr. Raju, can you please?
Yeah. So this child actually, that is a rare phenotype of a combination of muscle weakness and CNS involvement in the form of artistic features. So usually the common differential diagnosis we will consider is cerebral creatine deficiency initially thought of. So it was not suggestive of same thing because of she doesn't have much extrapyramidal symptoms, and also the urinary creatine levels was normal. So this tape, especially in the presence of multi-system involvement like muscle involvement, CNS involvement, and sometimes skin involvement, you should consider this rare entity. And in this child, actually, the muscle biopsy was done because parents were insisted, basically they want a muscle biopsy. That old physician at they want specifically muscle biopsy. That is the reason invasive test is done before genetic testing is considered. So any other comments from the case, any panelists?
Yeah, Dr. Veda, if you're there, can you have some comments? Or Dr. Renu?
Dr. Veda is there.
Already pointed out the diagnosis. Yeah.
I think the hard handles this case had was intellectual disability, autistic features, and skin changes. So the kind of ichthyosis which have shown in the neck, and usually this is generalized, especially on the legs and neck, it is present. And then the clinical diagnosis is usually a megaconial myopathy. We have seen 3 previous cases with autistic boys who had the features of myopathy, proximal weakness, and this kind of ichthyosis, which were previous cases were not confirmed, but later on, once the genetic is available, we could get the genetic diagnosis in those cases. But excellently presented case, very beautifully presented case. Thank you, Raju.
Dr. Veda. Yeah. Dr. Veda.
Ma'am, he has logged out.
Nobody is logged in again. As Dr. Sadish Kadilkar, na change karo naam fir. Anyway, others can comment, yeah, please.
Okay.
With the permission of the panelists, I would like to go ahead with the few description of the cases which we have seen.
Okay.
Can be a bit fast because
my only, this is a great case. I would have approached this as a progressive myopathy and gone for a biopsy, and would have picked it up on the muscle biopsy. I was wondering if they did do an electron microscopy, you would see those huge, large mitochondrial collections. But I would have, I would have probably, not been so impressed with the autistic features, but in hindsight, probably it was important. But I would have approached this as a progressive myopathy with high CK, which really, if you don't find the specific cause, would proceed with a muscle biopsy.
Thank you, sir. Can we move ahead or?
Yeah. So this is a new form of congenital muscular dystrophy due to homozygous compound mutation of CHKB gene. The peculiar finding here was it is due to a transporter enzyme mutation, which affects the mitochondrial dynamics, which has a characteristic mitochondrial displacement towards the periphery. This is a characteristic feature of this disease, and often has multi-system involvement, with CNS having intellectual disability, autistic features, and developmental delay, with a progressive proximal muscle weakness. Cardiac involvement often has a cardiomyopathy, ichthyosis and dry skin. A few cases having hearing impairment and seizures. We found 3 studies with the reporting these diseases. One study had 13 cases, other one was 15, and one was from the man's had 5 cases. Mean age of onset was around 2 to 2.5 years, with most of the cases showing consanguinity. Developmental delay, muscular dystrophy, and autistic features were the cardinal features were present in almost all the cases. and few cases around had seizures as well as ichthyosis and cardiac involvement as indicated. So takeaway from this case is this type of muscular dystrophy should be considered in children presenting with progressive proximal muscle weakness with intellectual disability and autistic features with the age of onset around 2 to 3 years, with the multi-system involvement having seizures, skin changes, cardiac involvement, and hearing involvement. Thank you.
Yeah. Thank you, Dr. Vikas. It's a rare case and very well presented. And thank you, Dr. Raju, for all the comments. So we move on to our last case. Any questions from the audience? I think we will take a bit later. So last case will be presented by Dr. Kaushik Raghunath from AIIMS Delhi, and Dr. Biswaroop will be moderating the case. So you can share your screen, Dr. Kaushik.
Yes, sir. May I start?
Yeah, please.
Okay. So, good evening, everyone, from the Child Neurology Division, Department of Pediatrics, AIIMS, New Delhi. Today, we'll be seeing 2 cases of chronic limb girdle weakness, ever-expanding twist in the tail. So here we have a child who presented with a 15-year-old, developmentally normal till 6 years of age, with no significant family history. He presented with complaints of difficulty in walking and climbing stairs since 6 years of age. History suggestive of proximal muscle weakness since 6 years of age, associated with progressive thinning of extremities and trunk since the onset of illness since 6 years of age. There was no vision or hearing involvement. There was no breathing difficulty or any history suggestive of cranial nerve illness. By around 12 years of age, 6 years after the onset of illness, he started having new onset paroxysmal movements in the form of sudden jerky movements of head, leading to head drop, often associated with sudden jerky movement of extremities also, around 10 to 15 episodes per day. This was not associated with any clustering or any relation to sleep cycle. This complaint was also ignored by the family. He was not given any medications. There was no associated cognitive decline, neither did he have any behavioral problems, no bowel or bladder abnormalities. So the child presented to us for the first time at 15 years of age. So at presentation, we noticed that the child had extremely thin build with marked generalized atrophy of axial as well as limb muscles. There was no dysmorphism or neurocutaneous markers. The environmental functions were normal, cranial nerves were normal, specifically no bulbar weakness or ophthalmoplegia, no facial weakness. As you can see in this video, he had a positive Gover's sign, and also mild waddling was noted while walking. He had hypotonia, proximal predominant weakness, quadriparesis with upper limb, neck more involved than the lower limb. Interestingly, he had normal deep tendon reflexes and flexor plantar response. There was polymini myoclonus and also tongue fasciculations. So we have a child, 15-year-old with normal till 6 years of age, progressive history of proximal muscle weakness, proximal more than distal, associated with progressive thinning of limbs. 12 years of age onwards, he started having myoclonic seizures on examination with findings suggestive of hypotonia, extreme wasting fasciculation with normal superficial and deep tendon reflexes, preserved cognition, cranial nerves, and bowel bladder functions. History-wise and examination-wise, we could localize to lower motor neuron pathology, most commonly anterior horn cell disease. So a chronic progressive neuromuscular illness with myoclonic epilepsy. Our first possibility was spinal muscular atrophy type 3 with epilepsy because he had early normal milestones. On examination, features suggestive of element pathology. 1 point against an alert was normal DTR. Second possibility we also considered was a juvenile ALS, amyotrophic lateral sclerosis. LMN findings with preserved DTR, a combination of human element always alerts towards this. Late onset Tay-Sachs was our third possibility in the setting of hypertonia, element features, and fasciculation. Although late onset Tay-Sachs usually presents during adulthood with ataxia, neuropsychiatric manifestations, but we have seen a lot of case reports of presentation with a wide age group, even in juvenile age group. Last being muscular dystrophy. In this setting, sarcoglycanopathy or BMD. Again, the points against will be no pseudo hypertrophy of muscle. Fasciculation is an important point against in seizures. It's not a very common finding. So with this clinical possibilities, he already presented to us with these investigations at the time of her examination. There was already a CPK done. It was mildly elevated, as you can see. Somebody has rightly suspected SMA. MLPA was done. It was found to be negative. And enzyme analysis, again, late onset Tay-Sachs was suspected. Hexosaminidase A was done, and it was found to be within normal range. And a whole exome revealed compound heterozygous missense variation in exon 12 and exon 2 of ASAH1 gene. We did a phenotype-genotype match of this. And of course, a child with SMA like proximal muscle weakness and a phenotype with myoclonic epilepsy, there was a match. We went ahead with investigations. MRI brain was done, which was normal, and EEG was done, which showed generalized discharges in the form of sharps and spike wave, slow wave complexes. Predominantly, they had, as you can see in the unipolar montage also, there is left frontal predominance FP1, F3, and with secondary synchronization. There were frequent runs of 2 to 3 hertz sharp waves and spike and slow wave complexes, each lasting for around 5 to 6 seconds. Basically, the background in sleep and awake was normal. Apart from the supportive management of SMA, we went ahead with starting levetiracetam and benzodiazepine, and we started seeing dramatic response within 2 weeks of initiation. The last visit was a week ago, and he had complete resolution of myoclonic jerks. A similar presentation, but this time a slightly younger boy at 9 years of age with no significant background of consanguinity, normal till 3 years of age. He started presenting with history suggestive of proximal muscle weakness since 3 years of age, and progressive thinning of extremities, again, no vision or hearing involvement, no respiratory or lumbar thickness, cranial nerve involvement. This child did not have any cognitive decline or seizures, no bubble bladder. So the first time he presented to us at 9 years, there was progressively worsening proximal muscle weakness, but he still was ambulatory with significant gait abnormality. So again, this is the video of the child, which shows a positive Gower sign with extremely thin built, again, generalized atrophy of muscles as in the similar case, and his higher mental functions and cognition was related. Again, this child had hypotonia, proximal predominant weakness, and with preserved reflexes, fasciculations, and interestingly, this child also had, as you can see in this video, he had fasciculations of the periscapular muscles also. So again, a clinical possibility was narrowed down to the same 4 differential diagnoses, but this time I would like to again stress that he did not have any epilepsy or seizures or cognitive decline. SMA type 3 was our first possibility, and we went again with investigating. MLPA was done, which showed again negative. So our next step was we did an electrophysiology and muscle biopsy. Nerve conduction study turned out to be normal. EMG was done, which showed features suggestive of chronic changes of denervation and neurogenic process. In muscle biopsy, there was basically preserved fascicular architecture and group atrophy of muscles, again, which points towards SMA. And we could see myosin developmental and neonatal pattern. Normally, the myosin developmental neonatal pattern, fetal embryonic patterns of myosin is not seen after 3 to 4 months of age. So this suggests primitive embryonic developmental arrest again. It's not very specific for SMA though. So whole exome revealed compound heterozygous missense variant in exon 12 and exon 2 of ASAH1 gene, and both the parents were carriers. This MRI brain was done after seeing this, in fact, seeing this genetic diagnosis, which was normal, and EEG was done, although he did not have any clinical seizures, that was also normal. So the supportive management was started and the child is doing okay. So basically, a broad workup approach to a child who presents with motor predominant symptoms with a history of chronicity or positive family history will point towards an inherited motor neuron disease. There can be 5 different types of phenotypes. One is isolated element syndrome, which can point towards SMA is the most common phenotype that we see. If there is element predominantly with additional features of epilepsy or deafness or skeletal abnormalities, we can take a category of SMA plus. If motor neuron syndrome is a part of multi-system disorder, we should think of INOD, infantile neuroaxonal degeneration, or AAA's Algro syndrome, or Chediak-Higashi syndrome. If there is a combination of UMN and element findings, juvenile ALS becomes a possibility. And if there is predominant UMN findings, hereditary spastic paraplegia will be a possibility. So among all these categories, just the conditions of SMA plus is quite interesting, which can also be mentioned as non-5Q SMA syndromes. It can present with predominant respiratory distress, diaphragmatic paralysis, SMART 1 and 2 phenotypes, with predominant scapuloperoneal weakness, and they can present as a part of mitochondrial disorders also. The second phenotype, SMA with CNS manifestations, can be seen in 2 different conditions. One is, as we are discussing, SMA PME phenotype. It is because of a genetic defect in ASAH1 gene. And second one is PCH variants, pontocerebellar hypoplasia variants. Third one is with SMA with bulbar involvement. There is a wide spectrum of manifestations. And last one is SMA can present with arthrogryposis as well. This is the gene of interest, which is ASAH1. As you can see, this image, this paper was reported in 2018. They have reported a multiple number of variations, missense variations or nonsense variations. Of course, the clinical phenotype, this explains the variation in phenotype with this condition. And interestingly, this is a very interesting paper in 2018. They have just consolidated all the cases. They have reported almost 43, and we could see, to the best of our knowledge, 52 cases have been reported so far of SMA PME phenotype. Most of them have their age of onset between 4 to 7 years of age, a previous normal period until 3 years or till 4 years of age, and average period of death is between 14 to 21 years of age. Why is it important to know the therapeutic implications? Because this gene ASAH1 has got a allelic variant of Farber disease clinical presentation also, where there are therapeutic implications of gene therapy, hematopoietic stem cell transplant, and enzyme replacement therapies being tried, where in our phenotype of SMA PME, it is mostly supportive management. Coming back to the gene, which is coding for acid ceramidase, the question arises whether is it a continuum or spectrum or 2 sides of coin. Usually, based on the literature review, there is no clear explanation for why there are 2 different variations. But one point has been stressed in most of the literature, that if the enzymatic activity of acid ceramidase is the enzyme which is going to cleave the ceramide into sphingosine and fatty acid. So if the enzymatic activity is found to be less than 10%, they present like Farber disease. The classical Farber, again, they have given 6 types of phenotypes in Farber. Type 5 has got neurological manifestations indeed. And the classical Farber is going to be early onset with deformed plainful joints, subcutaneous nodules, and hoarseness of voice because of laryngeal involvement. They have death before 2 years of age. Whereas the SMA PME phenotype, what we are talking about, they have enzymatic activity more than 10%, usually, sometimes even normal enzymatic activity. And they have different types of epilepsy as a part of presentation. Can be not necessarily myoclonic, it can be GTCS or absence or atonic. And hyperventilation and sleep activated discharges have been mentioned. In the later stages of time, they have mentioned sensory neural hearing loss, mental regression, and cerebellar involvement as well. So as you can see in this literature, in the reported cases, the enzyme level of acid ceramidase is mostly normal, or it is in few cases, yes, they are less than 10% as well. So If we have observed carefully, in both our patients, interestingly, we got mutations in exon 2. Both our patients had mutations in exon 12. Both our patients had the same defect and variant as in codon 172 and codon 1045. Basically, both our patients have the same mutations, same variation, missense variations. So why did one of a patient had seizure and one of a patient did not have? One possible explanation is that our first patient presented by around 15 years of age and the seizure started by around 12 years of age. And the second patient is still around 9 years of age. Maybe later age group of onset of seizure is possible. That is one possible explanation. So again, when we did a literature review, we could identify that there are few cases, very less number of cases where they have reported, even as you can see on the top, even ASA1 gene with no epilepsy also, with almost a normal lifespan also. And there are phenotypes where, as you can see here, two phenotypes where they have reported, one in a child, one in an adult, where it started with features suggestive of Farber. And later on, they continue to have SMA-like phenotype. So a mix-up variant is also there. Over to the panel.
Yeah. Thank you, Dr. Kaushik. It was a very well presented, and the discussion also we have summarized very well the types of SMA non-5q and SMA PME phenotype. So, Dr. Bishwarup, your comments for the case. Dr. Bishwarup is there.
Yeah, Bishwarup, you speak. Kaushik, stop sharing the screen if you don't have anything else to show.
So,
yes, ma'am.
Thank you, Kaushik, for a wonderful presentation. It was very lucid, and as Dr. Gurpreet pointed out, you have covered almost everything. So, you know, the
voice is a little low.
message. Can you hear me now?
A little more louder, please.
Am I audible now?
Yes, this is better.
Yeah. Okay. So, what I was trying to say was that, you know, Kaushik did a wonderful presentation. It was very lucid, and he covered, you know, the entire spectrum, starting from the clinical features to the discussion part. So the most important thing here is, you know, that the spectrum of presentation in spinal muscular atrophy is ever expanding, and more with coming up of SMA plus syndromes, you know, it has actually widened the scope of clinical presentation. In this particular case, what we wanted to highlight was, you know, that although this is an autosomal recessive disorder, the presentation can be variable. A little around, say, 52 cases have been reported 52 cases till now. And what we have seen after reviewing literature and from both these cases, what we have understood is that myoclonic epilepsy or seizures, for that matter, can come later. So at the beginning, it can be like a classical SMA3 presentation, which was our second case. In the first case, the child had already come with the diagnosis. What we did was just confirming it with genotype phenotype matching, and then subsequently doing an EEG to, you know, confirm the myoclonic epilepsy. The other important part is, you know, the overlap with Farber syndrome. So the overlap with Farber syndrome actually opens up, you know, interesting therapeutic avenues like bone marrow transplantation, then gene therapy, because both these have already been tried with promising results in Farber. So a new variant, which most of us are, you know, getting aware in the recent time, and it's just an ever expanding spectrum. But what is important is, many times it may come with the typical phenotype, but many times it may be just a classical SMA, and we may be actually dealing with an SMA plus syndrome. So we need to keep in mind regarding SMA plus syndromes in typical phenotypes and in classical SMA phenotypes. If we get SMN gene MLPA, and, you know, where both deletion and duplications are negative, we may have to think of SMA plus syndrome. So this was the takeaway message. In our case, why we did a muscle biopsy after we got an SMN, you know, MLPA negative, was that we felt we were dealing with either a myopathy or a dystrophy with, you know, which have low CPK values or near normal CPK values. But once we got an SMA-like picture in the muscle biopsy, we went ahead with an whole exome, thinking, you know, that most probably we are dealing with an SMA plus syndrome. So that's it from my side. Over to you, Dr. Gurpreet.
Thank you, Dr. Bishwarup. So, any comments by Dr. Veda or other panelists?
Yeah, that's very nice. And I've seen two patients with this, and the other one, which looks very similar, but again, it's a rare one, is DYNCH1 gene mutation. It can be, it gets dominant and it produces a SMA-like picture with lower limb dominance, and they may also have variable amount of cognitive impairment and seizures. So that'll come in there. So there's actually a nice review article about 3 years ago from in Neurology, which talks about the expanding spectrum of SMA. And I have 2 individuals who have, the transient TRPV4 gene mutation, which is transient receptor potential vanillide type. They again can have weakness with muscle atrophy, and it will look like SMA. So that's the reason, we need clear genetic testing before you consider gene therapy for this very reason. But the muscle biopsy is great. It's a classic root atrophy, which shows the whole vesicle had collapsed and become like string.
Thank you, sir. And if there are any questions so only one question for this case. For case 1, what was the background in EEG and any polyspike discharges? So the
Background was normal, sir. No polyspike discharges in this particular case.
Okay. Any other comments by panelists or?
Only one thing
No,
that yes, there are SMA plus situations, and we are starting seeing now. You have to look for it, and as Dr. Veda was mentioning, so we about the cases we've also been seeing lately. Dr. Veda, you were saying something, I think.
No, I just wanted to thank all of you, and
Yeah.
it was a great experience. I'll join this every week.
Yeah, thank you so much, and thank you for joining from the airport. Thank you so much.
Okay.
Anybody
All right.
else from panelists? Yeah, thank you, sir. Any panelist? Gurpreet, ask the panelist.
Yeah, Dr. Renu, you have raised your hand, please.
Thank you, Dr. Vishnu, for excellent case presentation. The non-5q assay, once you get an SMN MLPA negative, is in a kind of Pandora's box where you have so many different kind of genes and so many different presentations. So it's really difficult to diagnose, but with increasing use of genetics, we are able to see non-5q SMAs also. So GARS1, DYNSCH1, these are the one who presents with the in a non-5q SMA presents with severe wasting, upper limb predominant weakness, and some of these clues are there. So this is an kind of expanding area where the newer syndromes has been diagnosed, and we are more recognizing these cases.
So can we directly advise whole exome in such cases before going for MLPA? I mean, somebody has asked Dr.
I think
Mohammed.
muscle biopsy is the clue in these cases. So you have a kind of a group atrophy and hypertrophy, then your diagnosis is non-5q SMA, and you go ahead with in that direction. That's what I follow, but I can take we can take opinion from Dr. Prashant, Dr. Vishnu.
Dr. Veda, we would like you to have your opinion.
I would usually do an EMG that will give you a good focus, and then many times we'll go directly from there for genetic testing, and then biopsy. I think it's the choice, but I may end up doing EMG with the biopsy and then genetic testing. We have in US at this point in time many free genetic testing from multiple companies, so we have a luxury of ordering those easily. But I would approach with EMG followed by biopsy and genetics.
Dr. Rajesh, what are you seeing in the UK?
Yeah, well, biopsy is not commonly done these days with the, we'll do EMG, now conduction and genetics possibly, but I think in some cases obviously muscle biopsy could help here.
Prashant was saying something, no? Prashant, your thing was highlighted. Gurpreet, then you can just wind up. Ask everybody when anybody wants to say anything.
Anybody else who wants to add or ask some questions? So does EMG can be helpful? Dr. Deepak has asked. I think Dr. Veda has just commented upon that. Dr. Viswarup, what was the EMG like in your case?
So this child had neurogenic potentials. The first case was already diagnosed when he came to us with the classical phenotype. But for the second case, we went ahead and we could see neurogenic potentials. Was I audible?
Yeah. Got it. Thank you.
Okay. Yeah.
So, Dr. Mahesh, can you, should we wind up, ma'am? And
yeah, Dr. Rashmi, anything or anybody else wants to say anything?
Yes, I think these two sessions, the last one and this one, have been very good, very educative, and it's a very good format for such teaching. Online teaching is very effective. So we can, I don't know what format you want next time, Shifali, but these two sessions were very, very.
Whatever everybody decides, ma'am. I mean, everybody decide. You have to decide. You all have to decide. It's your decide. You decide. Dr. Naita, would you like to say something? And then, Dr. Veda, I want you to give a take-home message before you log off. I know you are in the lounge and you have to board the aircraft soon, but while Dr. Anaita speaks, you give us a take-home message for all. Yeah, Dr. Anaita.
I mean, it's wonderful. I mean, you folks are more thorough in your exam and differential diagnosis. Our folks, we tend to take shortcuts by genetics quickly, but still it was very, very educative. I enjoyed it greatly.
Yeah, thank you, Dr. Veda.
Yeah.
Dr. Anaita.
So I'm going to sign off if you don't mind.
Yeah. No,
next
thank you so much.
Okay.
Thank you so much.
Thank you.
Thanks. Bye. Safe travels. Bye. Dr. Anaita.
I think it was an excellent session. I like this format very much. I think for students as well as for us, great learning from it. I think this 1 month on each topic is a very good idea because it's more intense and it's more focused. So we're looking forward to the rest. I think we have one more, right, in the neuromuscular session. And
Yeah.
go on to the next one. Excellent.
Yeah, thank you. Raju?
Yes, ma'am. Nothing, ma'am. It is very good. Okay. Nothing to add.
Prashant, you wanted to say something in between?
No, ma'am. I'll just say that I also like this format where we discuss a lot of cases and we can have learning from other cases. So I'm very happy that others are also liking the same and we have good numbers who are turning.
Renu, कुछ बोलना? Take home. हमारे पास free genetic testing नहीं होती है. We have to have a history, an examination, have proper differential diagnosis. That is what, and we have to have thought. I mean, you can't just, like go and look for a needle in a haystack. You have to have a focused on history, and your examination is going to support or refute. That thought process has to be there. Renu, please. Let me say something.
The pre-test probability depends how like your test is going to be positive. So you have to have a good hypothesis before sending a genetic test. I think the format is really well. We have learned a lot and we got the opportunity to learn from different cases. I think we can continue with the same format. I'm happy that the session has been liked. So I think in the next we can plan further about treatable kind of neuromuscular disorder. That's what we usually plan. But I think we discuss in the session. Thank you, ma'am. Thank you so much for
Doctor. Thank you, Rajesh. You logged in. I know you were in the OPD. You logged in late. It's coming in your OPD times. I'm sorry. You're 4.5 hours behind us. So, yeah.
Thank you so much. It's helpful format. I agree, and I agree with you. Clinical examination, differential diagnosis is very important. And still be thank you for
Thanks.
all the team members. Thank you.
Yeah, I understand you're in the OPD area, so the signal is there. Vishrup, you want to say something before Gurpreet says, and then Mahesh signs off. Gurpreet has to give some take-home message too, huh?
I just want to thank Abhishek, Ruta, Vikas, and Kaushik for the presentation. And
thank you, nahi, kuch वैसे message देना, पढ़ाई वाला.
There were so many messages.
Eastern examination, we cannot leave. I mean, that's it, right? Yeah. Yeah. Mahesh, back to you.
There's 4 nice different cases presented today, ma'am. It was really nice learning. And we'll be updating about the next program in both email and WhatsApp, and I expect similar participation on next Wednesday also. And after this, starting from September, neurogenetic and neurometabolic SIG will be taking over. So next Wednesday will be the last session of this neuromuscular SIG.
Yeah, but in between, you also watch out for other sessions they will be doing in between. That will be the next in the Wednesday slot, but they will come up with probably workshops in Series B sides and beyond. And all of these will be being recorded, and Asmita will put it on the website, right? Yeah. Thank you.
Good night.
Thank you. Good night.
Thank you, everyone.
Thank you, everyone. Good night. Good night, sir.
Good night.
Good night. Thank you. Bye.